learning curves in image-guided spinal surgery and surgeon expertise, actually surgeon and technologists in the room and representatives in the room, their expertise, and how that decreases flow disruptions. The Medtronic research grants, all my disclosures. So we talked about some of this today about the negative perceptions of navigation. So lengthens operating times, but we actually showed that that wasn't the case, but that's a sort of a perception. Interoperative glitches, which we've talked about a lot, and the steep learning curves. Because it's a multi-systems, team technology, as Ken spoke about, all these people come into play. The surgeon, the scrub tech, radiology technician, image guidance technician, and the instrumentation rep. So unlike other technologies, it requires proficiency of all the team members involved. And so fluoroscopy, you have the surgeon, radiology tech, the scrub tech, while in the navigation, you have the surgeon, navigation tech, radiology tech, all these people. Thank Dr. Kim for that slide. So as Ken spoke about, this pit stop model, it's an idea that we don't really talk about too much, but it's kind of the way things should be done. Everyone knows what they're supposed to be doing, know exactly what step they're on. We don't see that so much in spine surgery or in surgery in general because there's so much advancements. There's intimate details of the machine that's really hard to know. And people are coming in and out, they have shift changes and whatnot, while we're still in the room trying to manage it. I always talk about how when Dr. Johnson's in the room, when I was at Cedars, he was like he's a cowboy, but he kind of herds the team. He kind of, he's getting everybody going, moving along, making sure everyone's doing the right thing at the right time. And, as Ken spoke about, you need that leader to kind of run it. But why is that? Why can't everyone else be up to speed? And part of that is, as Ken mentioned, is that requires education on every level. So this name I never can pronounce, and I'm sure Ken can't either, but this concept of flow, when everything's going right, this complete immersion activity, which is complex, purposeful, and rewarding. And actually, if you could find me on that top slide is when I used to row, but when we used to row, it was smooth. Everything would go right until someone would put the oar in the wrong way, and then everything would be disrupted. It's the same thing with surgery. Someone comes in the room, leaves the room. Oh, I don't know the back table, and everything sort of changes. So how do we get to that point where we understand flow? And so flow disruptions are these deviations from this natural progression of a procedure that potentially compromises safety or efficiency. It upsets processes, increases errors, decreases team resources, and potentially leads to worse outcomes. And so these are some of these examples of disruptions in workflow. We don't have to go through every one of them, but some of these things are patient factors, some of them are external, having to do with staff coming in that don't relay the information to the next staff member. And so what happens is that when these disruptions happen, it's sort of a snowball effect. It starts small and then starts building and building and building and becomes something significant and much larger. And these cumulative disruptions make mistakes happen. And so this human factors analysis, as Ken sort of represents, is this discipline that studies these factors. Why humans do what they do and how we could get better at doing it. And so we did this study here at Cedars-Sinai looking at our navigated cases. We had 31 expert surgeons and 9 novice surgeon cases. We had 1 observer, and he detailed notes of all flow disruptions, timings, and aspects of the case. And then we had them divided by parts of the case. So this is sort of the timeline of what it looks like. Call for the O-arm arrives, begins the process, spin initiated, and all these different parts were sort of looked at from the perspective of flow disruptions. We had 98 hours of observation, total 530 flow disruptions. There's the flow disruptions per case, about 14. If we had multiple spins per case, there were more disruptions as predicted. So here's some of the questions we asked. So when do flow disruptions happen? What causes them? So one thing we noticed is that the most common time was where screws were being placed. And what were the factors involved? So coordination. So the ability to communicate across the team was the biggest factor. As Ken mentioned, the equipment, some of these issues, whether it's reference frame or passing the instruments back and forth, that was a huge factor as well. The next thing we looked at is, are there unique flow disruptions patterns with each of these processes? So from the start of the case to when the O-arm was being positioned, to the spin, and to the screws. And so if you look at these, some of the data, it's really interesting. Coordination still, is largely predominates for most of the spots except for screws. And so, when I look at this data, I really start thinking about, okay, what can I take from this when I go back to the operating room? And obviously, you really want to make sure that everybody in the room has the idea that these are the things that we're looking out for. And part of the problem of this data is that how do you take this data and sort of grow from it? And that's what we're still trying to figure out. And then importantly is how important is expertise and experience to the workflow? So if the circulator, the IGS tech, the X-ray tech, the scrub tech, and all these people are involved. And so when you have an expert surgeon or an expert IGS tech, a circulator, all these things matter. The one thing that we noticed was that with the X-ray technician, with the expert, they had more problems than the novice, and I think a lot of that was because they were sort of arguing with our surgeon. They'd be like, "Oh no, I could do it this way," versus just listening to the surgeon. So that was actually a little surprising result. I think this was a thing that most people were kind of interested in. So how much time sort of is translated by these flow disruptions? And so if you have an expert surgeon, you reduce the flow disruptions by basically 5 per hour. If you have an expert technician who's running the image guidance thing, then you have 6.47 per hour reduction. And then if you have both of these people in the room at the same time, it's about 8 flow disruptions per hour. So, and this essentially translated to 14 to 42 minutes of delay in your surgery. So this could snowball more and more. So as we're trying to understand these sort of take-home points of human factors analysis, is that perhaps a way for us to create a pit stop model in spine surgery, and part of our other lectures with Raj talking about the Toyota production system, is that how can we increase our efficiency? How can we bring everybody up to the same speed and develop a learning curve that will be reduced for the entire team? And the goal is to integrate all these elements to reduce flow disruptions so that essentially we are all in the nice flow. So I want to thank everybody for your attention coming out today.